Okay, fantastic. So good morning, possibly good afternoon for some people, depending where you are dialing in from. Thank you so much for joining us today for our Improving Mainstream Health Services for People with Disability webinar hosted by Mission Australia. So Mission Australia is one of the partners in the community here in Perth, helping to deliver the NDIS through our local area coordination program. My name is Kimberly Ellis and I'm a community engagement facilitator. And we also have Bruce Gordon, who you just heard me chatting with. Bruce is also a community engagement facilitator as well, and he's just here with us in the room today providing some extra support. And I can just see people commenting in the chat box. Bruce will keep an eye on that, and he's going to try and help people troubleshoot any IT issues that come up for you as well. But it's really great that you were able to make the time to be with us here today. And I just want to let everyone know before we make a start that we are recording today's session, and then we will aim to make that publicly available as soon as possible after the recording has basically been finalised. Okay, so I just ask everyone before we start if you could put your microphones on mute, please. If you're not able to or not sure, Bruce will just mute it for you as well. And before we get any further, I'd really like to make an acknowledgement of country as well. So we acknowledge the traditional custodians of this land, the Whadjuk people of the Noongar Nation for us here in Perth, and we pay our respects to the elders past, present and future, for they hold the memories, the culture and the dreams of the Aboriginal and Torres Strait Islander people. And we recognise and respect their cultural heritage, beliefs and continual relationship with the land. And we recognise the importance of the young people who are the future leaders. We also understand today that people might be dialing in from lots of different locations across the country, but we would like to make the acknowledgement that no matter where you're calling in from, we're all on Aboriginal land. Okay, so basically the purpose of today's webinar is to help provide health professionals and those working in the health sector with information on some of the health specific projects which are currently funded through the National Disability Insurance Agency's Information, Linkages and Capacity, or ILC, Building Grant Scheme. And really ILC is all about inclusion. It's about creating connections between people with disability and the communities they live in. Unlike the rest of the NDIS, ILC isn't about providing funding to individuals, but it provides grants to organisations to deliver projects in the community that benefit all Australians with disability, their carers and families. However, just as a note, the ILC grants program is actually now being administered by the Department of Social Services. So if your organisation is interested in any upcoming grant rounds or information, then the best place to look for that will be on the DSS webpage. But today, very exciting. We're going to be listening to 4 different organisations who will deliver presentations. Basically, these 4 organisations have received funding to deliver projects that are focused on improving mainstream health services for people with disability. And we hope that today really serves as a nice opportunity for organisations to network, to create some new connections, and also to inspire each of you as individuals to really think about how can we improve the services that we work for. How can we ensure that our delivery of services is accessible and inclusive for all community members? Okay, so our presenters and presentations today, we have Dr. Saini Dalton and Dr. Sharon Boyce from Dietitians Australia, and they're going to be talking about their project called Capacity Building for Dietitians in Disability. Following that, we will hear from Nicola Hamilton from Scope, speaking on the project titled Best Care for People with Communication Disability. And then we will hear from Danielle Loizu Lake from National Disability Services to chat to you about the NDS's Ready to Go Home project. And our final presentation today will be from Natalie Graham and Naomi Lake from Down Syndrome Australia and they're going to present on Down Syndrome Australia's Inclusive Communication Project, improving health outcomes for people with Down syndrome. And I'd really just like to take a second here to thank each one of our presenters who've joined us today and basically made the time to come out and share with us about these exciting projects that they're delivering as well. Each presentation today is going to go for around roughly 20 to 25 minutes, and then hopefully 5 to 10 minutes for question time at the end. And as I said, we really ask that people keep your microphone muted if you can. If you can also keep your camera off, that just helps us. So when the presenters have their cameras on, that they'll be highlighted in your bottom taskbar as well. And I think as well, just the reason behind the mute is if you don't have your microphone on mute, it does pick up quite a bit of background noise, and it can really make it difficult for presenters to be able to hear. So you're welcome as well, as we go, to drop some questions in the chat box. If the presenters or Bruce can't get to anything, we will try and address it at the end as well. And then Bruce can also feedback those questions to the presenters during question time. If you require closed captions, you can access that in Teams via your toolbar at the top of your screen. For some people, it might come up at the bottom of the screen, but for most now on Teams, it'll be at the top. There's 3 little dots that you can click on, and then you can select to turn on live captions as well. So if everyone's ready, I think we'll make a start, just as well so that you're aware to keep things running on time today, because we know that some people might be dialing in at set times for a specific presentation. I will just sort of, even if questions start to sort of head over the allocated time, I'll just reel things in so that then we can keep to time and just accommodate for those people who might really just be dialing in for one presentation. And then we'll also, after this, we will be sharing some contact details for the presenters in a follow-up email. So you can always touch base with them after that and ask any follow-up questions you have, or keep up to date with the progress of the project as well. Okay, so that's it from me and in terms of the initial housekeeping. So I'm going to hand over now to our first presenters. So Dr. Saini Dalton and Dr. Sharon Boyce, if you're happy to share your screen and chat to us all through your capacity building project for dietitians and disability.
Thanks so much, Kimberly. Okay, I'll share the screen now. So can everybody see the screen? If anyone could just indicate, Kimberly, perhaps if you can see my presentation slides.
Yeah, absolutely.
Yeah, perfect, thank you. Well, hello everybody, I'm Saini Dalton, Senior Policy Officer at Dietitians Australia and Project Manager of the Capacity Building for Dietitians in Disability project. And today I'm here presenting with Dr. Sharon Boyce, who sits on the advisory group for this project. So the Capacity Building for Dietitians project is one of 28 projects that was funded by the National Disability Insurance Agency through the Mainstream Capacity Building Grant Round to undertake activities that build the knowledge and skills of healthcare professionals to work with people with disability and improve access to high quality healthcare services in the mainstream setting. And the purpose of this grant program really is to help people with disability to overcome the barriers they face in accessing high quality health supports in the mainstream setting, and ultimately to enable people with disability to access the same mainstream services as people without disability. So within this context, the current project seeks to build the knowledge, skills and confidence of dietitians to work with people with disability and improve access to dietitian services that are high quality, relevant and inclusive of people with disability. And our key project partner in this grant is the Australian Federation of Disability Organisations, who've been with us in this project from its conceptualisation up until now and moving forward. So in today's presentation, I'm going to give you a brief project overview, and then Dr. Boyce will give you her perspective on why she got involved in the project and the importance of dietitians being disability aware and appropriately knowledgeable, skilled and confident to work with people with disability, and the importance of all this to the community. But before we get started, I would like to pose a question to the audience to explore some of the professional barriers that healthcare professionals face in providing optimal services to people with disability. And the question is, how confident are you to provide services or healthcare services to people with disability compared to people without disability in your area of practice? And I've added a definition of disability at the bottom of the screen here as a reference point for this conversation. So disability may include physical, mental, or intellectual or sensory impairments, which interact with various barriers and may hinder people's equal and full participation in society. So reflecting on that definition and your current practice yourself, how confident would you be to provide a service that's safe and effective for a person with disability in practice? So if you're not so confident about providing those services, what would be some of the reasons for the lack of confidence? Does it relate to knowledge in a particular area of practice? Does it relate to lack of skills or experience with working with people with disability, or lack of resources? Could it be uncertainty around communication, or even navigating the NDIS, helping people to connect with appropriate services in the context of the NDIS? If you're a dietitian, it would be great if you could perhaps make note of some of the top level barriers and concerns that you might have, because there is an opportunity at the moment for that for you to feed that information into our project to help inform our priorities for our project. And I guess the purpose of really highlighting or thinking about reflecting on these gaps is that what we find is that they're quite common in the mainstream setting. And there's actually a growing body of evidence to show that this knowledge, skills and confidence gap is actually represents a significant barrier for access to high quality services for people with disability in mainstream setting. And there are a variety of reasons for this knowledge, skills and confidence gap, but part of it does relate to a lack of educational opportunities for healthcare professionals and a lack of resources to support practitioners to work safely and effectively with people with disability in their practice. So the mainstream capacity building program really aims to plug this gap in knowledge and skills of healthcare professionals. And the capacity building for dietitians project aims to build the knowledge, skills and confidence of dietitians to work with people with disability and improve access to high quality dietitian services in the mainstream setting. And we do this through the development of an education program and resources to support dietitians and their clients with disability. So this is a multi-phase project. So we're currently in the needs assessment phase of the project, which is all about identifying the priorities for the education program and the resources. The needs assessment will involve a systematic literature review looking at what are effective educational interventions and what can we learn from those educational approaches in terms of educating dietitians. There's also a desktop review that's happening to identify what education currently exists for dietitians and healthcare professionals and other situational factors that are relevant to the project. And then we have two key consultations that are happening at the moment. There's a survey to dietitians and there's a consultation with people with disability, family, their carers or support people. The consultation to dietitians is currently live at the moment. So we're actively looking for input from dietitians to find out their perspective on the type of education and resources they need to support their work with people with disability. And so this represents a current opportunity for dietitians to really get involved in the project and have your say about what's important to you in terms of education, and also just to engage with us generally around what are your barriers to practice, so that we can address that, formalise that, that information and build it into our program so it can inform our education, our priorities for the education program. And the consultation with people with disability will be happening over the next few months as well. We currently have an ethics application submitted to the ethics committee so that we can communicate the outcomes of that consultation process. So all of this needs assessment process will assist us to identify what the priorities are for the education program and resource development. And in the second half of this year, that's when the development of the education program will take place. This is another opportunity for any experts in the room, whether they're dietitians or people with disability or other organisations, to really get involved in the project, because we'll be tendering out some of this work to external parties to help develop that content. So please do get in touch if you feel that you have expertise and would like to contribute, or keep an eye out for Dietitians Australia communications so that you're aware of these upcoming opportunities. And then, of course, after the education program and resources are developed, the education program will be rolled out, and that will happen next year. So the education program could take the form of an online course or face-to-face events, or a combination of the two, really depending on what comes out of the needs assessment. And the resources will be rolled out in that timeline as well. So the last point I'd just like to make is that this really is a collaborative project. Our key project partner is the Australian Federation of Disability Organisations, but we're also guided by the expert input of our advisory group, which includes people with lived experience of disability, and 2 dietitians who have expertise working with people with disability across a range of different ages and with different types of disability. And we also have the team at Dietitians Australia, who bring their various strengths and skills to the project. And we have our research and evaluation partners and a range of other collaborators who we've connected with across the time of the project. So, and of course we have the community itself, and we have dietitians who we hope to engage now at this phase of the project and moving forward as well. So we are very well, our doors are open, and we invite you to get in touch and engage with us if you're interested in this project, or if you have thoughts or ideas about what you would like to see in terms of dietitians education. So with that said, I would like to hand over to Dr. Sharon Boyce to provide her perspective on why she got involved in the project, and the importance of dietitians being disability aware, knowledgeable, skilled and confident to work with people with disability. So I will hand over to you now, Sharon, if you're ready to jump in. Thanks, Sharon.
Thank you very much for inviting me to be part of this. It's a very exciting role, I think, to be part of this advisory group, and looking at the perspectives of what I myself can bring, and also within my role of chair of the Queensland Disability Council as well. I guess conversations with many other people with a variety of disabilities about diet and food and different things that I can feed into this group that I think really does help us as a society, really, to look at food, the importance of food, how we can look at diet, and how we can actually shape and get better ideas and educate a community about the things that we can actually do. And I guess I should put a bit of the perspective of my background. I wasn't born with a disability. I got juvenile chronic arthritis when I was 11, never thinking that would actually really alter my life in much of a way at all, and never sort of thinking about how different my life would be in my time now. So I guess I'm going to try and talk across the years of how dietitians have really linked with me and to enable me to, I guess, eat and explore food and actually, well, use food to something that is actually worthwhile for me. Because when I first got arthritis, there was no problem at all. I'd eat anything. There was no problem with actually biting, chewing, thinking about what I was going to eat. And I started to go to a dietitian because I wasn't eating very much because of medication. So medication really did alter the way I started to look at food. So that was one thing that I didn't realise that would overarch over all of the ways that I actually approached eating, what I liked, and how much it actually influenced what I was actually wanting to have within my diet. And then as time went on, there were many changes with my jaw, with chewing, with my teeth, with my neck. My neck broke because of arthritis. The bones just broke down. And so therefore there was lots of problems with swallowing and thinking about how I was actually going to get that food into my body. So there was a very different way for feeding and the process of eating. I also have to link in the fact that about 5 years ago I had to have a tracheostomy, and that again altered very much what I actually could do, could eat, and made me really aware of things that I was actually doing with the preparation of food that could make it much easier to eat and much more enjoyable that I never had to think about before. Just that adapted process of eating and choosing different types of food was certainly tested in the last 3 months, where I have been in and out of hospital a lot with sepsis. Now, that altered, of course, how much food I could eat or felt like eating. But the real understanding, and after being part of this advisory group and really exploring food and what worked for me, what worked for other people, what was good, what was healthy, what was nutritious, and how I was going to actually get it into my body, really made me aware of lots and lots of other things that was so important when it came to that eating process. In the hospital, there was so much thought about what I was going to eat, and then looking at that menu of what I was able to eat. And I think that was key, was really looking at how that food had to be adapted, what was prepared and what came actually in on that hospital's tray, and what I looked at and what I thought, and did I want to even eat it. So how do we make food attractive? How do we make food easy to eat? How do we give a lot of variety for all the different types of individuals who are eating that food? If we look at the issues of, I guess, cultural overlays with food, what people like, whether they like it spicy or mild, things like that. I also have to think very much about whether I'm going to be feeding myself or whether my carers are going to be helping me to eat certain foods, whether it's easy to eat, whether it's easy to swallow, whether it's, I guess, able even to be bitten. And that was some of the things that within hospital that I really had to explore. And in the end, it was quite funny when I actually left the hospital, and I was packing up and going home, and we were looking at what I actually had brought up to my hospital room. I had my own microwave, I had a toaster, I had a kettle, I had a smoothie maker. It looked like I'd moved in for, the whole year, which I was glad I hadn't. But I had to adapt nearly every single thing that came from the kitchen for me to be able to eat it. It wasn't that it didn't taste good, because the taste was there usually, but it was probably too hard, too soft, wasn't able to be bitten. Some of the things that I thought would be easy to hold or easy to actually bite just didn't work. And when I asked for things like, could we actually toast this a bit more, it never actually worked out. And so I think it's really important to actually educate why it's important that things are actually, cooked to a certain point, why things are cut in a certain way, and why the food actually is developed. So you really want to eat it so it tastes good. And I know for myself, I actually did a lot of fresh juices and took them to the hospital. But the importance of understanding how you can actually create a diet at home, wherever you are, that actually works very well for people with disability, I think is incredibly important. Food needs to be, I guess, explored. So all the things that are needed in a diet are there. It's easy for a person either to eat, to hold, to chew, to swallow, and all the different things that have to be factored in to that process. Who would ever think that eating and working out food situations and knowing the correct diet for your weight, for your height, for your body's nutrition would be so complex? Hey, we all know it is. But when you actually sit down and analyze it and write it down, I think the importance of education for dietitians, but for everybody, understanding and exploring what you can do that's easy. I guess I learned a lot when I actually got one of my blood tests back and I found out I had barely any potassium and how important potassium was for our body, and how just by eating a banana and putting that into a smoothie or changing the way that you actually added that to your diet could make such a difference to your overall health. So it is a matter of educating at a community level, at a, I guess, practitioners level, and our role in that advisory group, I think, is pretty special because we all have our unique ways of having to do something, and things that I didn't even think I would ever really like to eat have become the easy foods to eat and the go-to foods to eat. And I've added them into my diet, and it's been a lot more helpful. And instead of looking at food as a burden, to have to, oh, I've got to have that, that might not work for me. I've managed to work out a variety of different foods that I like, and then some real go to foods that I seem to have nearly every day or nearly every week. And I feel comfortable and confident eating those, because you have to really think about um, what you're choosing to eat and how you can do it better. And I guess I should also add in the fact that I do have diabetes, and I do have to think about those sorts of sugary foods or time of foods that I eat. Trying to eat on time, it's a real issue for me because I let my days go on for a very long time, and I often don't have my dinner till 11 o'clock at night. And that doesn't do good things for your diabetes. But interestingly, since I had sepsis and since I was in hospital, that diabetes and my sugar levels and a lot of those things that I was doing a certain way have actually changed. So monitoring those things and really being aware of how food can alter those, how medication can alter that, and how I guess disease processes can change, and keeping a real eye and monitoring how food and drink actually impacts on your life, when you eat, how you eat, what you choose to eat. And you've got to also, I think, very importantly, enjoy what you're eating. I really think that enjoyment and that eating of food. I know when my sisters came up to the hospital and they brought me certain foods and we sat and ate it together, it was a really nice experience. So I think that's something from the perspective of a person with a disability to really add into this equation is the enjoyment of food and how we can actually put those levels of appetizing food, healthy food, easy to eat food, good food to use for your body, exploring what your impacts are on your life. Like for me, it's my tracheostomy that I had and the scarring from that, the way that I actually use my body to eat and feed myself, independence with food and loving food, and thinking about how we can put all of these things and variety into that equation is so important. And I never would have believed that when I was diagnosed with arthritis when I was 11, that I would be thinking so much about food, so much about what we eat, how we do it, how we actually educate about food and the importance of that research about it and how we might be able to do things differently, how we can look at, protein drinks, the different levels of supporting our diet and the best ways we can do that and the sharing of knowledge in this area. And that's why being part of this group has just been, I think, a real privilege to be able to share my knowledge of that area and the impact food has on me, and for it actually be able to help shape, I guess, opinion and even my own opinion of what food works and how that changes over time, I guess, in relation to my disability and the impact that has on my life. So I hope that's been helpful to people, um, in that. And I know that we have some really great discussions in our group. And I think that those sorts of discussions have to keep happening. And the people around within our webinar today, the dietitians, but all of the different groups of individuals sharing that knowledge and actually making a difference for all the people that you work with, and families that you share with, can actually make a real difference to our community. And I think that the way that the NDIS has funded this project, really will be very helpful right across Australia to make a real difference in diet and the education and research across this area. So thank you, everybody. And I might hand back to Sadie. And if anyone has any questions, I think Sadie and I are going to answer them now.
Thanks, Sharon. I think that gives a really good, a great insight into why you got involved in the project, and I think really highlights the importance of, dietitians, but also all healthcare professionals being, disability aware, and also aware of the central role of food and nutrition in the health and well-being of all people, and the importance of healthcare professionals, I think, making those reasonable adjustments to, to support people with disability to meet their food and nutrition requirements, whether it be in the hospital or other settings. So thanks so much for sharing your story and insights there, Sharon. I really appreciate that. And I think now we could probably hand over to the audience. Do we have a minute or two for questions?
Yeah, absolutely. You've got about just over 5 minutes if people would like to ask questions. And so it might be easiest at this point, unless you wanted to put your contact details on the screen, just to either stop screen sharing or, yes, perfect.
Yep. We're really
sorry, Saini, if you are just able to drop that Teams view, we're able to see your Teams view as well.
Okay, sure. I was monitoring for questions, but yep, no, that's fine. If you can just let me know if anything pops up, that'll be great.
Absolutely. On that note, you've got 2 questions have come through.
Sure.
One, so we've got from Melanie Shear, has asked, how do dietitians access the survey? And the second question, is HEN, H-E-N, included in scope of the project?
Well, okay, so in terms of the first question about the survey, I will send that to you, a link to you personally, Melanie, so thanks for your question. And also the survey has been advertised in Dietitians Australia Communications, so it's in our weekly newsletter, and there was a targeted email sent around to dietitians, and it's in SharePlate as well. So, but if you don't access those communications channels, that's okay. We'll make sure that we send a link around to the participants in today's session. So I'll definitely get that link to you. And the second question is hen included. Well, I guess we're open to hearing about any sort of barriers or any requirements for education around hen. That's certainly within scope. I'm not sure exactly what aspect of hen that you're interested in, but I think it's all, we're open to hearing from, any of the educational requirements that dietitians might need could be, theoretically be covered. So yeah, I think that would be in scope.
And Melanie, did you want to expand at all around your question? If so, you can unmute your microphone and just have a chat.
Oh, hi. Hi, Saini. How you going?
Hello.
Thank you for the presentation. It was great. So my name's Mel Shearer. I'm from the Agency for Clinical Innovation in New South Wales, and we, in our nutrition network, we have the Home Enteral Nutrition Network, and we have a large membership of dietitians, and enhancing skills and having a better understanding on how to support our clients who require hen services is an often a requested thing. So we're really keen to see and hopefully see that there's going to be some a branch of education that's looking at that as well, how to support those clients, or even something as simple as report writing, all those sorts of components.
Perfect.
But,
yeah, I think that's absolutely within scope. It would be really great to formalise that request through completing the survey, because that will help too, because we're obviously looking at all of the dietitian requests around education. So if we can collect that information from you, that would be really good. And I'm happy to send you the survey link so that you can participate in that survey and share it with your colleagues. But I also do make note of requests that come through like via email or member inquiries, so that will feed into our needs assessment and consideration of all of the potential topics. But I think that's an important one. It's certainly one that has come across, has been asked of me in the past as well. So yeah, I'm more than happy to hear about those interests. And thanks for reaching out and attending this session today. It's really important that we do engage with you now, but also engage with dietitians throughout the life of the project. So if you have ideas, please get in touch, and all of that gets taken into consideration.
Thank you. Thanks, Mel. Thanks, Saini. So, Saini, we have another question that's come through, and we might put this just in terms of time as the last question.
Sure.
But absolutely, there'll be opportunities for anyone in the room to reach out to Dr. Saini and Dr. Sharon at a later stage. So Meg has asked, thanks for the great presentation. How do we get this great information to other people and their families and carers nationally? And Meg says the question is from Robin Timms, physiotherapist in Perth, also interested in rural and remote clients.
So the information, do they mean the information about this particular session or the survey? Which part of the information were they wanting?
Meg, if you're there and able to unmute yourself and just expand a little bit, that would be excellent. If you're not sure how to unmute yourself. Okay, so Meg's just written in the chat box, it's about the session and the information from Sharon.
Oh, okay. Well, Sharon, did you want to
yeah, okay.
jump in there at all?
Meg, that sounds really good that you guys are interested in the physio. That's exactly what I am hoping, that by being part of this project, I know that that's what Saini's working on, is sharing this information out. And I guess from where my perspective is, definitely rural and remote, and those areas where we're looking at Indigenous health and we're looking at multicultural and different backgrounds of eating and crossovers with disability. If there's any questions that people have, and I guess the work that we're doing as a team and I'm sure Saini will support this, is if people are interested and want more questions, we can get information out there. And I guess linking in to my story, and each person with disability story is different. It's absolutely unique, and the frameworks that frame what I am able to eat on a certain day, even whether I can actually, you know, bend my arms well to feed myself, whether I feel like I want to be very independent, just thinking about the sort of things that I eat, even how I cut food, I think can be very useful for other people with very similar disability. And I've learned from other people when I'm watching them when they're out and how well they seem to eat, and how I've had to adapt to the way that I do that. But I also have to love what food I'm eating. And I think to share that information really makes a difference to us. It makes a difference to the community and to the food that's nutritionally going into our bodies. So that's so important. I think that's why this project is so important. That shared body of knowledge, that research. And I know that if people get online and can link into the survey and feed more stuff in, then we can feed more stuff out. And that way it's going out and coming in, and we're making a real difference, education and research wise, across Australia.
Right.
Yeah, thanks, Sharon. And yeah, also, yeah, please do reach out if you have more specific requests and interests related to your area of practice. I think rural, it can be sometimes a bit more difficult to connect with dietitians and people with disability in rural settings. So that would be really valuable input into the project if we could hear a little bit more about what your interests and needs are. So it'd be great to follow up and have a bit more of a conversation.
Great. Look, thank you so much, Dr. Saini and Dr. Sharon, for your time and your presentation. We'll wrap that one up and move on to our next presentation.
Thank you.
But I did just want to feedback as a final note that Meg left you a comment saying Sharon should go on ABC Q&A program.
Well, thank
now,
you very
Saini,
much.
can I just ask, Saini, can I get you to stop screen sharing, please?
Yep.
Thank you. Perfect. All right, so on that, I would just like to introduce our next presenter. So we have Nicola Hamilton is presenting from Scope. So Nicola, I'm going to pass that over to you, and if you're happy to screen share and start your presentation.
Thank you, Kimberly. Hopefully everyone can hear me and see the screen.
Yes, we can see.
Excellent. Okay. I would also like to begin by acknowledging the traditional custodians of the lands on which we're all on today, and pay my respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander peoples attending today. So as Kimberly said, my name is Nicola Hamilton, and I'm a speech pathologist and project lead for Scope's project, Best Care for People with Communication Disability, enhancing communication between health professionals and patients during medical emergencies. So thanks to everyone for tuning in today, and to Mission Australia for hosting. All right, so what I will cover over the next 20 minutes or so, I'll give a brief overview of who Scope are, what do we do, what is communication access and the communication access symbol. I'll give you a background into Scope's ILC project, the needs analysis, an overview of the stages and evaluation, and then probably most importantly, how is that relevant for you? All right, so I'm here today representing Scope, which is one of the largest disability providers nationally, offering services to over 6,000 clients and their families. Scope's mission is to enable each person to live as an empowered and equal citizen. So let's stop and think about what the words in this slide actually mean. You know, if we were to personalize this and say, what I want is to enable each person to live as an empowered and equal citizen. You know, it seems like this is largely about access and removing any access barriers. So having equal access goes a long way to creating equal citizens. Access barriers can be physical or built environmental, or in the social environment, interpersonal environment. So for equality, both really need to be addressed. Taking lessons from the International Symbol for Access, Scope developed a symbol for communication access in collaboration with people with lived experience of communication disability and the Communication Access Network. And today we'll be discussing the project which aims to reduce barriers some people may face when accessing emergency health services. All right, so before I jump into what communication access is, I'll just give you a little background to our services. So I work in CIRC, or also known as the Communication and Inclusion Resource Centre. And that's a division of Scope that houses a number of individualised and capacity building or access services. The Communication Access team to which we belong supports a range of different businesses and organisations to become communication accessible. Over the period of my presentation, I would like to share with you what communication access is, and to understand why now, of all times, it's so important for healthcare services to be communication accessible to people who experience communication difficulties. And that includes providing, written information in more accessible formats. So, what is communication access? And what do we mean by it? So, communication access occurs when people are respectful and responsive to individuals with communication difficulties, and when strategies and resources are used to support successful communication. Really, it's when everyone can get their message across and understand information that is given to them verbally and or in writing. When we talk about communication access, we imagine it being the final piece of the accessibility puzzle. I'm sure we're all familiar with the range of accessibility symbols found within our community. So there's the physical access symbol, the person in the wheelchair, which is one of the most recognisable symbols in the world. It's often displayed on ramps, lifts, and other environments that are physically accessible for people who may use mobility equipment like wheelchairs, walkers, or scooters. There's the adjustable volume telephone symbol, the Auslan signing symbol, signs for people with vision impairment or the deaf or hard of hearing. So hearing loops, teletypewriter or TTY symbol, and then of course Braille. The communication access symbol, which you can see on that top right, the blue one, it really focuses on people. So when people see this symbol on a website or a reception desk, they know they are engaging with an organisation that takes accessibility and inclusion seriously. They know they are engaging with an organisation that has made an investment in their own staff, and that really ensures that no person goes unheard, and that all people or patients, inclusive of those termed vulnerable or diverse, are able to communicate in a way that works for them. So the symbol is internationally registered and copyrighted, and the standards that underpin the symbol were registered with the Australian Competition and Consumer Commission, the ACCC, in 2014. This basically means that organisations or services that display the symbol are legally bound to comply with the communication access standards that the symbol represents. In this current COVID pandemic, arguably communication access is even more important to organisations who might be changing the way they deliver services and communicate with their service users in new and innovative ways. And that could be through telehealth or any other means. I'm sure many of you have experienced firsthand the effect that mask wearing can have on people's communication styles, and the extra difficulties that are faced when we don't have a range of non-verbal communication methods to get our message across. So we need to ensure access and inclusion remains at the forefront so that people with communication difficulties aren't discriminated against. Okay, so I'll take you through our project on creating communication access in emergency mainstream healthcare. But this is just a little snippet of some of the stats that demonstrate the need for more accessible services. So over 1.2 million Australians have a communication disability. 420,000 have a severe or profound communication disability. 24% of adults with disability experience very good or excellent health, and that's compared to 65% of those without disability. Excuse me. And people with disability experience poor health and engage more often with mainstream health services than those without disability. I just wanted to show, hopefully this works, show this video, and please let me know if the sound doesn't transmit. And it just shows, it's an example of work that we did with Victoria Police, but I guess it demonstrates the importance of communication access in emergency situations. Hopefully you can hear it.
Sorry, Nicola, I'm not sure if other people are getting sound, but it's not coming through. I can't hear it.
It's not coming through. Just a second. No, it's not. It does have captions, so hopefully it's easy enough to follow along with. And apologies for the volume. I can put the link for it into the chat. Oh, no, it's stopped. I can put the link for it into the chat also. After. Kimberly, do you think I should just leave the video for now and continue on?
If you think with the captions that people will follow, then absolutely play it. And I can also share the link in the follow-up email that I send through to everybody too.
Thank you. Thanks. All right, I'll continue to play it. It does have captions. Apologies about the sound issue with that. Okay. All right, so just on to a bit of the background and overview for our project. So Scope and its health system partners will develop training and communication resources for workers in emergency health services across the patient journey. So that's from initial contact so calling 000, through first response and treatment by ambulance officers, and then handover to hospital emergency department staff. Funding is secured for 3 years until the end of March 2023, and we will initially focus on a number of metro and regional pilot sites in both Victoria and South Australia. So the aim is really creating resources and trainings that can be accessed by healthcare organisations and groups across Australia. But the idea of doing the pilot sites is really testing it in those settings first. Okay, so let's have a look at the project design and stages. The work that we are undertaking with each of our healthcare partners will be following a tried and tested process. And this is the process we use when supporting any organisation to become communication accessible. So I'll take you through a quick overview of what this might look like for any organisation that were to undertake accreditation. Phase 1 or stage 1 covers identification of service gaps for people with communication support needs through a pre-intervention staff survey, mystery customer evaluation, or role play evaluations. Obviously, in a healthcare setting like an emergency department, it would be role play because we can't really go in as a mystery customer or a mystery shopper into that situation. So the final component of this stage is the staff focus groups. And these are used to identify the types of communication tools and messages that would be most useful for those day-to-day interactions with patients or service users. In that second stage, we take the data that we've collected and create a number of resources that were identified. And then we test these resources with consumer testers who have a lived experience of communication disability and or literacy difficulties if it's accessible information. The data also goes towards tailoring the training for the specific groups. In the healthcare setting, obviously we'll be working with ambulance workers, we'll be working with call takers, we'll be working with nurses, medical officers, allied health, and so we want to make sure that the training is really specific for each group. Once the resources are finalized, training is rolled out to all front-facing staff and is presented by a speech pathologist and a person with lived experience of communication disability. So within our team, we have a number of trainers and assessors with lived experience of communication disability, and they've been trained up and qualified to be able to provide these services. And this gives staff the opportunity to familiarise themselves and practice using their tailored resources that are created for their setting and the communication tools, and they get to practice using that with a person who might use a different way of communicating. So then going on to stage 4, we repeat the assessment phase, once again surveying staff and assessing through those mystery customer style evaluations or role plays. And this is really to determine whether there has been an increase in staff skills and confidence in interacting with patients with a communication disability. And also to determine whether the 10 minimum communication access standards have been achieved and whether they can be accredited with the symbol. So once the organisation is accredited and allowed to display the communication access symbol, they then enter into sustainability phase. So this phase is really important to ensure that communication access is maintained, because remember, access here lies with the skills of the staff. We often think of physical access, it's often more permanent. So once there's a ramp that has within standards it meets the standards, that ramp would be in place until maybe the standards change. But, staff turnover, lack of practice, it can mean that elements of communication access within a team or within, a setting can be lost. This gives you an idea of our timeline. I mentioned earlier that our project is funded for 3 years. With the global pandemic, the irony that this ILC grant round was around mainstream healthcare, and then we literally in the same months that it was announced, there's a global pandemic announced as well. So there's been obviously changing priorities of some of our mainstream healthcare partners, many of whom were within Victoria, and so we've had to adjust our timelines accordingly. I just wanted to highlight that the resources and tools are still in development, so they're not yet available for national dissemination. Okay, how is this relevant for you and your organisation? I could go on all day about the ins and outs of the project, but the reason I guess you're here today is to find out about what services or what knowledge is there that might be relevant for your service or organisation. Okay, so towards the end of 2022 and the start of 2023, we hope to launch our online information hub that will allow health professionals, services and providers to access resources created through this project, including tailored e-learning packages, communication boards or communication books or other communication tools, and accessible written information. So these resources will have been tested in the settings that they were designed for and refined based on feedback from staff and the patients or service users who may benefit from their use. I also just want to put out there that we tend to focus on our communication tools and resources being for someone with a communication disability, but we have found through our work with other organisations is that they can be really beneficial for CALD communities. So for people who have limited English, they can be very useful there, and also for the ageing. And another finding from that ABS study was that older Australians will access healthcare services more regularly than younger Australians as well. So there are benefits across other populations. And also just to add, we've also received ethics approval from the University of Melbourne to research the outcomes for staff members involved in the pilot. So we are hoping to release the data that we gather throughout this project and the impact that the training and the tools has had on staff members. All right, services. So I know obviously the end of 2022 or start of 2023 seems like a long way away. If you did want to start exploring now how you can create more communication accessible services in your organisation or your service, please feel free to contact us, and Kimberly, I'm sure, will share my contact details, but I will put it at the end also. So we offer in-person training, face-to-face or via virtual platforms. And as I mentioned earlier, it's presented by a speech pathologist and a person with lived experience of communication disability. Our particular team is based in Victoria, and we have travelled to other states to provide training, but we do have authorised partner organisations in both South Australia and New South Wales who can provide that on the ground face-to-face services there also. We offer e-learning packages of 3 modules covering communication access, disability awareness and accessible information, or easy English. The accessible information team provide translations of complex documents and forms into easy English or plain language formats If you're not sure what that is or what it means, feel free to Google or search our website. We do have a number of free resources there. There was a whole package of easy English resources for COVID-19 and the restrictions. So resources around mask wearing and what to do when you're not feeling well. There also was keyword sign posters, social stories, and communication tools there as well. So just to give you an idea of the type of what we produce and put out. That's just an example there of the Easy English documents that we put together for the COVID-19. All right. Also, organizations or services that decide to undergo the accreditation process receive a license to display the symbol, and they're advertised on the directory of communication accessible places also. All right, so I'm coming towards the end. Just in terms of ways to be involved in the project. If you are a person with lived experience of communication disability, or you may support someone with a lived experience of communication disability, and you'd like to share your experience of accessing emergency healthcare services, please feel free to contact me. We do have a consumer advisory group that's held online, so location really doesn't matter. And we use that group to really put together discussions and gather information from people with that lived experience. But we're also running one-to-one interviews to gather further feedback on people's experiences accessing emergency healthcare. So if you have a story to tell and you would like to share it, please let me know. And finally, you know, if you're here today representing an organization that's interested in finding out more about providing CA communication access services in your state, you know, feel free to get in contact. We are trialing some different models as we roll out our services nationally. So yeah. So I think that brings me to the end. I hope time-wise that I haven't been too quick. But just wondering if there's any questions. I can't see what has come up on screen.
Not a problem, Nicola. I'll feed it back to you. Time-wise, absolutely perfect. You've got a few minutes to spare for questions.
Great.
We've had, and once I read this one out, if other people have questions they'd like to ask, feel free to unmute your microphones and shoot them through. But we have a question from Robin Timms from WA.
Yep.
Robin has said, great example from Victoria Police on communication access and the PIN. Can WA be another pilot site?
Yeah, so I guess within the remit of the current project, we have the budget is allocated in terms of our project partners. But if it is something that, you know, there are other organizations out there that are interested in being accredited or being involved in that, definitely get in contact, because, you know, we have worked with a number of different organizations. The work we did with Victoria Police was also through another grant, because we obviously realized that for organizations it can be quite difficult to fund themselves. So we do often work directly with organizations to explore grant opportunities. So yeah, I would get in contact. But as I say, within the remit of the project, we have our set pilot sites now.
Great, thank you, Nicola. Fantastic. Did anyone else have any questions for Nicola? Okay, you can always shoot them through to her at a later stage. Nicola, I just had one question to ask. In terms of people keeping up to date, I know you said that the resources would be made available via the website or the hub, but in terms of keeping up to date with the progress on the project, how are people, what's the best way for people to do that?
Yeah, I guess there's can be a few ways. So checking out our website, because there should be updates there once, because that launching that hub is part of the project for us, but always just getting in contact with us either. We can put together, if there were a number of people that did want to follow the progress and be informed when those resources are made available, if we can make a list so that we can send out communications to keep everyone informed closer to the time.
Great, thank you, fantastic, and thank you so much for the presentation. It's such a valuable project.
Thank you. I'll stop sharing.
Beautiful, thank you so much, Nicola.
Thank you.
Okay, so next up, I would like to welcome, we have Danielle Loizu Lake and Jennifer Hart from National Disability Services, and they will be speaking to everybody about the Ready to Go Home project. So I'll let you guys take the stage.
Can you see my screen?
Yes, we can.
Presentation? Great. It's one of those really strange ones where I can't see myself, so I'm hoping that you can see everything that you need to. My name is Danny, and Jen unfortunately can't be here now. She's been dragged off to something else. And Jen is actually from Department of Health. So this project is a partnership between National Disability Services, which is the peak body of disability service providers across Australia, and the Chief Allied Health Office, which is part of Department of Health here in WA. So I'm here to talk about the Ready to Go Home project. I would like to recognise that I am presenting here today from Wajak Noongar Budja, which is in Perth. I'd like to pay my respects to elders past, present and emerging, and recognise that sovereignty was never ceded. So the Ready to Go Home project. This project is, as I said, a partnership, and it really is a true partnership. So even though I work at NDS, I am based a few days a week at the Department of Health office, and Jen comes over to the NDS office, and just by nature of our working relationship, we really do already, I guess, through that representation, represent the disability health interface. And that's a huge issue, as many of you would know. The two sectors have a long history of barriers, particularly around housing and other issues, which I'll speak to. But we know that the way forward is to reduce the barriers around the disability health interface. The little image that I've got up here on the bottom of that slide really shows the intention that we're holding as we move throughout this very complex project. The hospitals are a big part of it. So in WA, Department of Health is the many of you would know this, is the overarching or administrator of health services, and then all the different health services or hospitals are their own statutory authorities. So that is already a complex thing within itself. People with disability move through these different hospitals. They can sometimes fall out at certain points, and particularly if we have co-occurring elements such as disability co-occurring with psychosocial disability or complex communication, then we see that things can become really tricky for someone in the health system. At the moment, there is 130 long stays in our WA hospitals, and long stays mean when they are past being medically ready for discharge, and they are essentially, for lack of a better word, stuck in hospital. And there's lots of reasons for that. People with disability and the health consumers experience this, some more regularly than others, are also a big part of the project. We have people with lived experience of long stays working alongside with us all the way along through the work we're doing. And then disability service organisations in WA, similarly working alongside and part of this project. So there's a lot of interface in every element. These are all happening consecutively, and it's a lot to juggle, but it creates for a very dynamic and exciting project that is demonstrating how these two systems can work better together. Okay, presentation, are you going to click forward? Here we go. Okay, the project timeline, this project started last year. It's around this time last year. It's a 3-year project that will go through to 2023. And we've established the steering committee, which is, I'm just going to jump forward and show you that, because in order for us to be able to move across the interface effectively and to develop better systems or processes or ways of working, we really needed to have all the agencies and sectors that are involved in this at the table. So we've got, as you can see, the NDIA, People with Disability, NDS, us, Department of Communities, the Mental Health Commission, Disability Service Organisations, WA Primary Health Alliance, Health Service Providers, so this is the hospital, Disability Advocacy Organisations, Department of Health WA, and the Aboriginal Health Council of WA. Our steering committee is made up of very senior or the highest level representatives from these organisations, and we're having conversations about how we can work together, which, as many of you know, is a pretty big step forward just in itself, that we're all at the table having conversations about how we be better at this. If I go back to the timeline, the project did a literature review, and I would say that the literature around essentially facilitating better discharge, which is kind of what it comes down to, and how we support people with disability to move through this system, and not just through, but it's around. Some people will need to interface with our health services. Hopefully we can capture more of that at a primary health level. Some people will need to go to hospital, but how we have that move around can be much more effective. And discharge planning is coming up as a big issue. The Summer Foundation in Victoria and New South Wales did a lot of, well, all of the eastern states actually, they did a lot of work on this, and they have done the only other literature review in this space. Our literature review adds on to that and develops further on this piece of work and evidence base. We've been working with Department of Health to develop a data snapshot around who's currently in hospital with disability, what the barriers to their discharge are, and that's being tracked every month. So that is particularly useful for being able to see what's happening in real time in our WA hospitals. And we are about to embark on a pilot with Rockingham General Hospital to really get more of a narrow focus on what the issues are, how we can work together with clinicians and health consumers and the community services that will provide that, that support when people move out into community, how we can all work together to implement strategies for improvement, essentially. The project will then go on to do more pilots, and by the end of its work should have worked with 6 health services. This is a literature review, and as I said, you're welcome to read it and have a look at it. It's written really well. It's written in really easy to follow language, and it really highlights what the current issues are and what the possible solutions are. And when you have a look at this, what becomes really evident is we know most of this stuff, but it really does require all of us to be doing our part. So sometimes you have health services or hospitals saying, the NDIA should be better at that. That's the NDIS's responsibility, and maybe not understanding that the NDIS is in fact an insurance scheme that is there to provide funding. And it provides services. The disability services or community services sector provides the supports that respond to the funding. So there's a lot of learning around this change that needs to happen. And similarly, disability service organisations are developing their capacity around what does the hospital need to be able to support someone with complex disability? What does that look like? Does the support worker need to come in to assist with meal times? Do we have the authority to be able to do that in the hospital? Do we have the support worker capability to do that? Do we have the consent to be able to do these things so the person can more effectively move through that system and back into community and or their own home or whatever that looks like for them? So this is a slide here, and I'll explain what the yellow bit is in a moment. But the literature review essentially said that there are these 4 main barriers to discharge. So this is why people with disability get stuck in hospital or stay longer than necessary. So uncertain prognosis and predicting length of stay in newly diagnosed cases, okay? Poor communication between health professionals, patients and their family. Poor collaboration for NDIS readiness between health professionals and those involved in the decision making. Now, what you might have already realised is that this stuff is happening before we were even getting outside of the hospital. This is the stuff that's already happening. So there is quite a focus on internal systems and how the hospitals themselves have internal capacity to do this work. And then we're moving across the interface now. So waiting on supportive needs such as assistive tech, home mods, appropriate housing or behaviour support. Anyone that works on the Disability Health Interface knows this is a huge issue. And with the Quality and Safeguarding Commission coming on board at the December last year, disability service organisations are reluctant to take on the risk around if someone has if someone has behaviours of concern, can we respond to that in a positive way? Can we implement the supports that they need in a community context so they're taken care of, and also the support workers and the people supporting them are? So this is a really interesting space. Home mods and assistive tech takes a long time to get. If we're talking about an insurance scheme, it's the same as when you have insurance for your house. If your house burns down, you don't just say to your insurer, my house is burnt down, I expect you to replace it and send all the people and, you know, I want that to happen tomorrow. It just doesn't happen like that. You need to be able to provide evidence. Excuse me. That's better. You need to be able to provide evidence of how much that is going to cost. Is there the market that can respond to the particular type of building that you need? It's the same. I don't want to say unfortunately, because the market-based scheme can work really well in some cases, but in other cases, often where there's complexity or nuances around how we support a person, these supportive needs can be very thin markets. And maybe that's the reason why people also stay in hospitals, and the hospital can become maybe the provider of last resort in some cases. These last 4 are all around housing. So lack of or limited access to ongoing rehabilitation care, assessment and planning for ongoing care after discharge. Lack of knowledge about all of the alternative accommodation options during hospital discharge. So for the clinicians or the health professionals in the room, I would like you to have a think about, if I was working with someone and they were in hospital and they had certain complex needs, or they needed specific supports because of their disability related needs, what housing options are available to them? What are those pathways? How quickly can they come through? Are they there? So there's a lot with the NDIS coming on board. This is where the market has created a lot of opportunity. Before this, maybe something like residential aged care was more of a regular option. That's not only on the nose now, but it's legislatively not appropriate for people under the age of 65. So we need to look at what housing pathways are, and we need to all understand what they might look like and how supports can be put in place. Unavailability, inability or lack of appropriate next level care options. So in WA, we don't have many transitional care options, and for different disability types, whether it's physical or psychosocial, those transition care environments will need to look different, and we probably do need some more capacity in that space. And then, of course, we all know, it's been in the media a lot before the election in WA, is the lack of available, safe and accessible accommodation options in the community. And we know that as we move further out into regional and remote locations, that this becomes such a huge issue, and people are really very limited. Now, getting back to why some are yellow and why some aren't, well, only one isn't, is that when Department of Health did the data snapshot or collected all the information from the public hospitals across WA on why people were staying beyond the date of discharge, all these ones in yellow came up. The interesting thing to see was that the crossover is there. The issues are what was demonstrated in the literature. Are we getting any closer to making improvements on this? Well, that's what the Ready to Go Home project and a bunch of other things that are happening are intending to address. So some of the strategies to improve hospital discharge processes, according to the literature review, is, surprise, surprise, to initiate discharge planning at the earliest possible time in admission, possibly within the first 24 to 48 hours of admission. So if we go back to the housing piece, or maybe some supports that are needed because of a person's disability, that takes time to get, particularly with the insurance scheme model. We need to get the funding. So there's this whole lot of administrative processes with the NDIA to get that. There will need to be evidence to support why that funding is needed. And then we can then look at market and see which provider might be able to respond to that. Provide each patient with 2 highly skilled and knowledgeable coordinators, an inpatient coordinator and a community care coordinator. Now, that's essentially the social work. The inpatient is essentially the social work or the allied health within hospital, and the community care is the support coordinator role. So under the National Disability Insurance Scheme, a support coordinator or specialist support coordinator should be doing the community care side of things. We know that we need to request NDIS and other funding as soon as possible. I've been to hospitals where, and even service providers in the community that still aren't sure how to fill out an access request form. What evidence do we need? What is functional language? How do I translate medical language into functional language? These things are really important to learn. This is not just the responsibility of the NDIS, it is the responsibility of all of us. Improve communication, collaboration and coordination between medical staff, allied hospital staff, patient, family members, community service and key stakeholders. Communication just keeps coming back. We all need to be better at communicating in a person-centred way. And engaging external advocacy services, this was specifically, because this came from the literature review, this was specifically around neuropsych, so when there's ABI or psychosocial. So that was quite specific to that, about what people do when they're discharged to community, that some disability types need more ongoing support and will need to be monitored more intensively post-discharge. And providing family and carers with the training and support in preparation for their post-discharge roles. So coming back to this guiding intention, keeping in mind that the Ready to Go Home project is working with hospitals, is working with people with disability, and is working with disability service organisations. The current projects that we have happening at the moment is a pilot or trial with Rockingham Hospital, including Mimity Park, which is the mental health unit there. We have commenced as of last week the work with our co-design team. So these are health consumers with disability that have had long stays and are helping us to map their journeys, identify the barriers from their lived experience, and then co-develop and co-design resources and improvements that we identify with the hospitals. Disability service organisations. Last week we had an incredible forum where around 50 DSOs came together and talked about what the experience is from their side. And we got some really interesting information which we'll collate, and this will all be shared. The Ready to Go Home project will share this all on our website. It's all available. What's really interesting is across all of these areas, so going back to this, is the incredible goodwill. It doesn't matter which particular group we refer to, everyone wants to make this better. And I'm not sure whether that's because the NDIS has put a spotlight on disability within mainstream services. There's lots of potential factors that have influenced this, But I will say that it is really encouraging that there is so much interest in people that would otherwise be quite marginalised. And I must say that some people that are currently stuck in hospital have been there for years. So housing focus, working with Department of Communities, NDIA and social housing providers on improving pathways. That's a piece of work that we're doing at the moment, and we're currently advertising for a project officer in housing. That job ad closes on Wednesday. So co-design, I'd like to talk about co-design. Now, for those of you that work in the health services, you'll know that when the McGowan government came in, that there was this sort of rethinking of how we, sorry, someone just needs to put their mic on mute, of how we approach our health services. So they are very expensive, our health services, and the Sustainable Health Review came into play to be able to look at that. So one of the recommendations, actually recommendation 4 of the Sustainable Health Review, I'm just going to let you read that while I have a little drink of water. Is that consumer and carer voices are embedded into the health system governance structures and make consumer, carer, clinician partnerships and co-designed, so the actual word is in there, co-design projects, a normal part of business. So for all of you that work in health or are health professionals or clinicians, I'd like you to have a think about, are you currently doing any co-design work? What is that? Is it true co-design? And are we really hearing the consumer carer voices in how we are approaching our professional work? The State Disability Strategy Action Plan also talks about any development of any new resources should be co-designed with people with disability, hospital staff and mainstream health services to support discharge. Okay, so what is co-design? There's lots of different definitions, but I'm going to use this one for the Ready to Go Home project simply because it talks about delivering in public services. And this uses the word co-produce. So just bear with me, I'll explain the distinction in a minute. But if we're talking about what is co-design, it means delivering public services in an equal and reciprocal relationship between professionals, people using services, and their families and neighbours. Where activities are co-produced in this way, both services and neighbourhoods become far more effective agents of change. Now, I know that the word co-design gets thrown around quite a bit, but I must say that in health, when health services come into the picture, I do come back to this and wonder whether services are being delivered in an equal and reciprocal relationship. And as professionals, we often can be professionals. I have a health background myself. I'm also a person with a disability. This is me swinging around in my wheelchair. And I think that sometimes I see both sides. I can see how living with disability and being reliant on the health system can be a really vulnerable space. And also, as a professional, we get taught how to do all these things in a professional way and what is right for the person and the systems or the processes that person should fit in. And I really do think that a bit of a mindset shift, as we've gone from in the past, we do two people. And I think that when we do two people, we take away their agency. And when we take away their agency, that can manifest in other ways that is not conducive to health. We then move to a place where we would do four, really kind-hearted, empathetic, we're doing for the people. And you still see this sometimes in a charitable model where we do for people. I'm not saying that that is not a good thing to do and that's not a wonderful thing to hold in your heart. But I do think that to give marginalised people true agency where they can be more effective agents of their life, then we need to be working with. And that working with can have very powerful results. So this is from the Mental Health Commission and it's the continuum of co-design. I would say though that co-design is not always the right approach for the work that you're doing. Sometimes you may need to simply inform. Sometimes you may want to consult. But co-design is a great opportunity when there's a project to be developed or a system refinement, or when you really want to understand why something isn't working the way that maybe the system or service thought that it would. Co-producing is the next level up again, and it usually means that essentially, as it sounds, you produce more together. It's more from the production phase rather than designing is more on the when we get to designing an element or a part. You'll see from these little pictures here that the Mental Health Commission has put in their approach that where the arrows go. So in inform, you can see that the arrows go out. And I think that that's really poignant to see, because I'm the authoritarian. I know what is right for you. I may not have ever walked a step in your shoes or know anyone that looks like you or lives like you, but I will inform you because I know what's right for you. So I think that where our society is moving, that can become a little bit of dangerous ground. Yes, there is time for that, but in developing health services for specific populations, it might not always be the right approach. Educating is the opportunity to come back and maybe ask a question. And then consulting is when you're asking for feedback. And then, of course, co-design, I'm just going to skip involved, but co-design is that lovely, equitable around process. Co-design should also be enduring. It shouldn't just be one workshop. It should be enduring and over time. And I like to bring this up because I think that as health professionals, we know that there are knowns, things that we know, and we know that there are things that we don't know. We also know that there are unknown unknowns. So I think most of us people would say, yep, I'm sure there's things out there that I don't know what I don't know. But then there are also unknown, I mucked that up a little bit, but I think you know where I'm going with this, is that there are unknown unknowns, and they're the things that are our total blind spots. So I know I've talked a lot about co-design, but I think that from a project or a service implementation perspective, and particularly with the Ready to Go Home project, we don't want to miss things. We have a huge issue that has been around for a very long time. And if we want to make improvements, we need to uncover those blind spots. So we need to be in the blue area. And I think that co-design provides us that opportunity. It also allows us to work with people as we go along. And from a risk mitigation perspective, it helps to avoid those things like PR disasters where an organisation does something and I think this is great, this is so good, this is going to be good for the people. And then they put it out and then some advocacy group or the media get a hold of it and go, oh gosh, that was terrible. They missed that. They were not in the right space. So good practice. I know this is a little bit of a funny activity, but it will remind you of what Danny was talking about with the Ready to Go Home project, is that I might see the rabbit and you might see the duck. And no matter what you say, I might never see the duck and you might never see the rabbit. But if we can work together and develop a shared space around being able to look at it and see the duck and look at it and see the rabbit, then within that shared context is where I think some really amazing work happens. And that is what we're doing with the Ready to Go Home project. So whether that's with clinicians, and I'm talking at the highest level within health services, from executive all the way through the health services, people with disability and the disability service organisations as well. How am I going for time? Pretty much up for time, I think. So our pilot project with Rockingham General Hospital, there's 4 stages. And as you can see, we're working at the executive level first, developing a steering committee and reference group to ensure this is driven throughout the system, and then identifying the issues with clinicians and also the patients with disability. We have to go through some ethics to be able to do that work, which I'm really thrilled that we're being able to do. And again, that's the goodwill of the health services in really wanting to be better at this. The project will then summarise the issues and create solutions, and then we'll implement them, we'll test and try them, and then we'll evaluate them. And as the project evolves and it moves throughout Western Australia and out to the WA Country Health Services as well. Hopefully we're all increasing our capacity and developing some good processes as we go along. So that's it from me. If you've got any questions, please shout out. I'm going to unshare this now so I can actually see who I'm talking to.
Great. Thank you so much, Danielle. Such a fantastic project, and so great the holistic approach that's being taken and the different stakeholders and the buy-in, I think, is really incredible. We're almost ready for the next presentation, but I do just want to open up the floor. Does anyone have any questions for Danielle? There's nothing in the chat, but would anyone like to ask any while Danielle's online? Okay. Just had some feedback about a great presentation. I absolutely agree. Again, we'll share Danielle's contacts then, and you can follow up if there are further questions that anybody has. So thank you again, Danielle. Okay.
Thank you, and please do reach out. Thanks.
Great. So we have our final presentation for today, which I'm very excited to announce. So our final presentation is from Down Syndrome Australia. So I'd like to welcome Natalie Graham and Naomi Lake to take the stage. So I'll let you guys screen share and away we go.
Hi, I am Natalie Graham. I am the Health Program Manager for Down Syndrome Australia.
Good morning, everyone. My name is Naomi Lake, and I am a Health Ambassador for Down Syndrome Australia in Western Australia.
So today, Naomi and I will give you a brief overview of the Down syndrome itself and a background as to why the ALC funded grant is so important to us. We'll then explain a bit about how DSA is intending to carry out the grant and where we're up to at this stage. Feel free to ask questions or put your hand up at the end, that's absolutely fine. And Naomi and I are going to present this together. So I'm going to share my screen now. Can everyone see that?
Not yet.
Not yet. Let me try it again. How's that?
Yes, we can see
Yep.
that now.
Okay. All right. Naomi.
Inclusive communication. Improving health outcomes for people with Down syndrome. This is us at the launch of the Health Ambassador program at Parliament House in Canberra last Monday.
So as I said, we'll give you a little bit of a background for those that don't know the specifics of Down syndrome. So basically Down syndrome occurs at the conception. It's the most common chromosomal anomaly that you can have. People of all backgrounds, ages and nationalities have children with Down syndrome. Down syndrome occurs where there's a partial or full extra copy of chromosome number 21. And the birth rate for Down syndrome in Australia is approximately 1 in 1,100 births, which equates to approximately 290 births each year. Not many people know there are 3 types of Down syndrome: trisomy 21, which is the most common and accounts for approximately 95% of all people with Down syndrome. There's also translocation, where one of the chromosomes attaches to another chromosome, which is usually chromosome number 14, and mosaic Down syndrome, where some of the body cells in the bodies have 46 chromosomes and some have 47. This is the least common form of Down syndrome.
There are approximately 15,000 people with Down syndrome who live in Australia.
So as Naomi's just said, there are approximately 15,000 people with Down syndrome who live in Australia. And those 15,000 people are genetically more like their families than they are like each other. They have their own individual personalities, their strengths and support needs that can't be predicted before or at birth. In general, people with Down syndrome have moderate to mild intellectual disabilities, low muscle tone, and higher chance for some health issues, but most of these health conditions are treatable given prevention. Most people with Down syndrome now live well into their 60s and longer, and they can lead a full and healthy life. With the appropriate supports, people with Down syndrome attend mainstream schools, they participate in meaningful employment, and they continue to learn within a supportive environment. Everyone with Down syndrome has a right to be a part of the decisions that affect them. They have a right to access appropriate medical intervention in a timely manner. Support in all its different forms is the reason that I live a happy and fulfilling life. And that's a quote from one of Down Syndrome Australia's board members, Claire Mitchell, who has Down syndrome herself. So the reason behind the grant and the reason that we applied for the grant is due to the Roundtable on Health of People with Intellectual Disability, which was held in 2019, and they're just about to hold the next round of the Roundtable. And the Roundtable showed that researched evidence was that there were health and inequalities between people with intellectual disability and the general population. And approximately 50% of health conditions of people with an intellectual disability are undiagnosed. And most of those are not related to their disability itself. People with an intellectual disability have approximately 2.5 times the number of health conditions as those without an intellectual disability. And they have higher rates of inpatient stays and longer stays, as we've just heard from our previous speaker, within the hospital. And then obviously that results in increased healthcare costs. People with an intellectual disability have very high rates of premature and potentially avoidable deaths. And practitioners are untrained and inexperienced in caring for people with an intellectual disability, as has been shown today already. So in 2020, Down Syndrome Australia surveyed the experiences and thoughts of people with Down syndrome and their interactions with healthcare workers. We received about 85 responses to our survey, and one of the questions that we asked was, what would you tell a health professional when they see someone with Down syndrome?
Number 1, speak slowly using plain language and visual supports. Give me information to take home with me to look at later. Number 2, be patient, listen to me. Don't assume, give me time to answer. Number 3, don't treat me as Down syndrome. I have Down syndrome and my medical issues are related to me. Number 4, if I choose to have a support person with me, I want you to speak to me, not the support person. They are there to support me to understand, not you to explain.
So looking at communication and communicating with someone with Down syndrome, the 85 participants that responded to our survey came up with these 3 silos. And basically, as Naomi has just said, give me time, give me support, and use a language and a communication style that is appropriate for me. So I'll give you a chance just to have a look at those. I won't read them all out to you. Some of the things that I will highlight though is speak respectfully to me. Often people with Down syndrome and people with intellectual disability as a whole can understand more than they can express. And that's a really important part of what we're looking at within our grant. And ask open questions and give me time to process the information that you are telling me. So the other thing that we found was, which is very important, is language. And this goes across disability as a whole, but focusing on particularly on Down syndrome. Use person first language. It means that he or she is a person with Down syndrome. And as Naomi just said, she is not a Down syndrome person. Down syndrome is a condition. It's not a disease. People don't suffer from it. People have Down syndrome. And because they have Down syndrome doesn't mean that they are abnormal. Everyone is an individual. And one of the things that we have, Down Syndrome Australia has also been very strong in advocating is using balanced language, using especially with the prenatal testing, that you have a chance of having a child with Down syndrome, not a risk, which has a very different implication. So our project. Our project essentially has two major components. The first component of our project is around supporting people with a lived experience to take an active role in sharing their experiences with healthcare professionals. Students and professionals seeing people with intellectual disability as an authority on giving information and knowledge will create a significant shift in attitudes and understanding. And as we've just heard, co-designing. So Down Syndrome Australia has recruited 10 adults with Down syndrome from across Australia to be health ambassadors. This is a paid casual position for all 10 of the health advocates, and we have at least one person in each state and territory. They have completed formal training in speech and presenting, delivering to set them up for success. We completed an 8-week online speech and public training session with a trained speech delivery person. Our aim is to go into education and clinical settings and to teach healthcare workers how better to include people with Down syndrome in their own health conversations. This is 3 of the health ambassadors last week in Canberra at the official launch, and each of the health ambassadors has their own story to tell about their health experiences within the health system. They want to share this information with healthcare workers and students to ensure that in future, people with Down syndrome get better access to quality care and are included in the conversations. And Naomi is now going to present to you her speech that she designed over the last 8 weeks. Are you ready, Naomi?
Yes, I am, Natalie.
Okay, go.
Okay. One of my favorite quotes is from Piglet in Winnie the Pooh stories. He said, "The things that make me different are the things that make me me." I would like you to think about that for a moment. It is important for you as a health professional to have better understanding of people with Down syndrome. Although we may have Down syndrome, we are individuals and need to be accepted, respected, and treated as such when we attend your practice. For example, some of us need help with communication, some of us need time to respond, and some of us require pictures to help us to understand. When you communicate properly with us, you will be able to obtain proper medical history and be able to diagnose and prescribe the correct treatment. And I'd like to show you a story. Last year, I had to have a tooth extracted from the roof of my mouth. This was a very scary thought for me. When we arrived at the hospital, the receptionist asked Mum to fill out a form about me. She didn't speak to me. Even though Mum gave me the form to complete, I felt unhappy about being ignored and not involved. It made me feel more anxious. As I sat in a waiting room with my mum and dad, I felt very nervous about what was going to happen. When the nurse called me to go into theatre, I asked if Dad could walk with me to help me stay calm. I tried to explain this to her, but she didn't have any empathy or understanding and just said no, Dad couldn't come. She said that she had lots of patients with Down syndrome and that I will be fine. She didn't treat me as an individual. She made me feel like I didn't exist. She needed to give me time, and she needed to have patience. She needed to make sure that I knew what was going to happen. Understanding people with Down syndrome is beneficial for your learning and professional development, and you will become a better healthcare worker. It will also make your job easier if you treat us as individuals. Be friendly and show interest in us, and you will soon get information necessary to help us to help you. To learn more about people with Down syndrome, please download the app Ask About Down Syndrome, available from Apple Store or Google Play. All the people have the right to the same quality of care.
Thanks, Naomi. So that's one of 10 health ambassadors who have devised their own speech, and that's their own health story to represent and self-advocate on behalf of other people with Down syndrome. You nailed it, Naomi. Well done.
Thank you.
So the second part of our project, sorry, Naomi. The second part of our project is about training and delivering training support for people that are working in the health industry and that are starting to become part of working in the health industry. So using our health ambassadors as self-advocates and creating different online and presenting different forums for people that are training and are working within the health industry. Obviously, in the world of COVID, the e-learning packages are more pertinent, but definitely we want to go and visit different healthcare settings and get people to speak with our health ambassadors and to ask them directly how they feel about being treated in the health industry. So the development of training is the second part. It is in the early stages because we believed that the focus should be on recruiting and training up our health ambassadors to set them up for success. We also had our major launch of our health ambassador program at Parliament House Monday week ago, the day after World Down Syndrome Day, which was the 22nd of March, which was a huge success. We had the Honourable Stuart Robert there and many other ministers. So it was pretty amazing, wasn't it, Naomi?
Yes, it is. Yeah, and I say is a well experience for all of us as health ambassadors, because it's not many who get to meet the ministers.
That's right, and we went to Government House in the afternoon for afternoon tea, and His Excellency and Miss David Hurley and Mrs. Hurley were there too, so that was pretty special. We had a great time. The other part of our project is developing tools for people with Down syndrome to better understand their own health. And one of the things that we have done recently is a video for people with Down syndrome about the COVID-19 vaccine. And I'll just play you a little bit here so as not to take up too much of the time. I'll give you a quick introduction. This is Amelia and Emily, who are health ambassadors from Victoria, and they interviewed one of Victoria's top infectious diseases doctors.
Hi, I'm Emily.
So hopefully this works.
And I'm Amelia. Hi, Professor Richards. Thank you for joining us.
We are health ambassadors for Down Syndrome Australia. Today we are going to ask Professor Michael Richards a few questions about the COVID-19 vaccine.
Hi, Emily and Amelia. Thanks very much for having me today.
What is a vaccine?
A vaccine is a type of medicine that we take to prevent a disease, not to treat a disease once it's started.
So I'll put it on pause there for you because it goes for about 5 minutes. But basically we understand and know that if people with Down syndrome want to educate and be educated, it's really good to be educated by peers. And so Emily and Amelia agreed to interview Professor Michael Richards there, which was really good, and it's being shared on social media and on our website. So the inclusive communications the Inclusive Communications Project is groundbreaking in Australia. It's the first project to look at and tackle the inequalities for people with Down syndrome by employing them to break the cycle of stigma, misinformation and lack of awareness about intellectual disability.
Don't focus on Down syndrome. Look at me and my symptoms as an individual. Try to understand my forms of communication.
And that's about us for today. So Kimberly, as Kimberly said, she'll share my details and how you can get in touch with us. I'll just stop sharing there. There we go. That's better. Now I can see everyone. So yeah, we're really excited about our project, really excited about our health ambassadors, and all of the health ambassadors have varying different types of communication and very, very different health stories that they look forward to sharing with everybody in the future. Any questions? Oh, Naomi, would you like to say something?
No, I just say thank you for your time and attention.
Thank you. Any questions?
Thank you so much, Natalie and Naomi. You've just had a question from Saini about sharing your email address, which I can send that through to you, Saini.
Terrific.
If anyone feels brave enough to unmute their microphone and fire out some questions. Okay, brilliant. There's a question that's come through in the chat from Nicola, and it says, very interesting project. Thanks for sharing. I had a question for Naomi. We run training for our presenters. What did you find most useful in your training to help get you ready to prepare for presenting?
Well, I say it's very useful to learn a lot throughout the presentations of the process, and of the process, and because his name is Peter, so and he taught us really well and the feedback we were getting is the feedback we were getting is so the feedback we get is really positive and really positive, and when it comes to so the feedback there actually was very positive anyway, and looking forward to present was very helpful.
Can I add one thing to that, Naomi? Is that all right?
Yeah, I do need some help anyway, Natalie.
No, you're doing a really great job. So one of the things that that when we did our training was that we got our core message. So Peter helped everyone work on their core message and the 3 parts of making up a speech, didn't he, Naomi?
Yes, he did. Yeah, the 3 parts was the beginning, middle, and the end.
Correct. Yeah, and so that helped all of us. And so just to let you know, whoever asked the question, one of our other health ambassadors delivered her story at Parliament. So Emily delivered her story, which had the beginning, the middle, and the end. And personal experience is one of the things that Peter taught us all as well, didn't he, Naomi?
Yes, he did.
Because only you know your own story.
Yeah. Yes, I do. I say Peter was very helpful in that way. The way he helped me with the core message is, I say, it's very emotional.
Beautiful. Thank you both so much. Were there any other questions for Naomi or Natalie? Okay, if not, we might wrap up to today. So thank you again so much to all our presenters. I think I speak on behalf of everyone who's dialed in today that it's really, really wonderful to hear about the great work that you're doing in the health space. And it's really exciting to think about the improvements that your projects are going to make for people with disability when they access our mainstream health services as well in the community. I'd like to just thank everyone as well who's taken the time to dial in today. We really hope that you've learned something new of interest, or you see an opportunity to connect or network as well. If anyone who's dialing in had a group of you in the room, it would be really, really wonderful if you could just put a note in the chat box to just let me know how many of you were dialing in, just in case there's, 3 people in a room or 4. It's just great for us to capture that data as well. As mentioned, I will send a follow-up email through to everyone. We'll have a survey in there where you can give us a little bit of feedback. That way you can let us know what was helpful from today. You can also give us some suggestions of if Mission Australia do something similar in the future to this webinar, how we can do that better as well. And then also really, if you think there's a need for any other information, what type of information is there an appetite for in the health sector too? Oh, also in that email, just for reference, I will put a link if you'd like to subscribe. We do at Mission have a monthly newsletter that we put up. The other things to just let you know is on that email, we'll have a link for Mission Australia's Eventbrite. It's in my email signature. So both our website and our Eventbrite, but that's where you can basically just keep in touch with us, see any other upcoming webinars. Obviously today we had an ILC focus, but we do run a range of webinars around NDIS as well. And that's basically it from everyone. So thank you so much for your time, and I look forward to your feedback, and I hope everybody has a really lovely day.
Thank you.
Thank you, Kimberly. Yes, thank you, Kimberly.
Oh, thanks, Kimberly.